Mula. Okay, selamat pagi kepada semua. So, kita akan mulakan sesi CME hospital kita pada hari ini. Dan izinkan saya perkenalkan diri. Nama saya Teoh. Saya pegawai farmasi, klinikal dan juga merupakan Ketua Pusat Sumber Maklumat Farmasi dekat Hospital Sungai Maliha. Hari ini, tajuk yang akan saya bawakan kepada semua berkisar tentang perkhidmatan pharmacist-led services. Kalau dalam bahasa Inggeris, we call it pharmacist-led services in ambulatory setting. How can we help? So first of all, when we're thinking about the term pharmacist-led services, it means that this service is taken apart, facilitated mainly by a pharmacist in the ambulatory care setting. So if you go to clinic, the first thing that comes to mind is to see a doctor. But today, as the world has changed, our practice has evolved. You can go to a clinic and see a pharmacist at first. So maybe we will ponder, is this something that has been happening in our setting or in our nation? Yes, it is. In our hospital, we have various pharmacist-led services which are ongoing currently. To evaluate and optimize patients' adherence to pharmacotherapy, and at the same time, we help to address any other drug-related problems. So, kiranya kalaulah pesakit itu jumpa doktor dan dia mengalami masalah mengenai ubat, sekiranya terdapat farmasi dalam perkhidmatan tersebut, maka pegawai farmasi dapat mengenal pasti masalah yang berlaku sebelum penilaian doktor lakukan. So that means we are here to reduce your burdens, our prescribers. So why do we need to have a pharmacist-led services? There's been an extensive literature review going on worldwide in the past 20 years to evaluate the effectiveness of pharmacist-led services. You can just go to Google Scholar and just Google any of these keywords and you can find numerous papers in different range of services that we have. So I'm not having the space for me to put up a lot of data here, but I'm going to give a very brief generic idea on why we should have a pharmacist-led services today. Theoretically and practically, it helps to improve adherence to our pharmacotherapy. When you're seeing a pharmacist at first, we as a drug experts, we are able to counsel and what are the underlying issues that the patient was ongoing. Kalau ada masalah pasal ubat, dia jumpa dengan farmasi terlebih dahulu dalam klinik tersebut, maka farmasi akan tolong buat counselling ataupun kita akan buat assessment. Kita juga pihak farmasi telah menggunakan berbagai jenis cara untuk mengenal pasti kepatuhan pesakit. Kita akan kira pill, we do pill countings. We even have a Malaysian medication adherence assessment tool, MyMat, to assess patients' adherence in a very holistic manner, I can say, because the questions and the scoring methods are all well validated in our country. So from all this, we are actually cutting out the time before they see the doctors. And this has been widely or extensively studied in the literature. So you can see a lot of papers saying that they have statistically significant improvement and so on in various settings. So most important practical point we can say here is to reduce prescribers' workload. So when they are seeing the pharmacist at first, while the patient is waiting outside, when it comes to the prescribers, we already provide you a very good progress note on these patients. So what you need to do is just to verify our points and to evaluate if our suggestion is suitable for you. That's all. So in my previous setting, before I came to Langkawi, I'm also a MTech pharmacist in respiratory. So I help my doctors in KK to evaluate my patients' inhaler therapy and so on. So our job is very much appreciated in my previous setting and also in the current setting as well. So let's have a look on what are the range of pharmacist-led services in our hospital per se. So I basically divide them into two major divisions. One is called MTech. We call it Medication Therapy Adherence Clinic, which was actually initiated by our pharmaceutical services division by then, at least as early as 2004, 2006. So it is started as early as that. Then throughout the past 14 years, it has evolved and developed to various range of disciplines that we have. But for our hospital per se, we have four main MTechs we have. One is diabetes mellitus. Diabetes mellitus has been one of the MTechs that has been given very high limelight by JKN. Kita siap ada KPI pengarah kesihatan tindakan bersepadu diabetes untuk memastikan bahawa pencapaian dari segi HbA1c dan sebagainya adalah diambil tahu. Maksudnya dia punya peningkatan tu ditunjukkan sebagai KPI pengarah. So maksudnya di MTech ni diberikan banyak penekanan dalam kita punya penjagaan farmaceutical. Padalah juga dengan statistik epidemiologi di mana Kedah merupakan juara diabetes di negara kita. The next is respiratory. Asthma and COPD patients, bila dapat lelah ataupun COPD, dia banyak perlu menggunakan inhalers. They are bound to a lot of inhaler therapy. But the inhaler technique, the compliance, and any adverse drug reactions following the inhaler therapy was very, very important before we can say that this patient is not really effective using the treatment. So before you try to escalate the treatment, you should refer to us. Let us do the job for you. We will help you to evaluate all aspects before we're sending to the doctors. So in respiratory MTech, we take care of patients with asthma and COPD. We do peak flow meter. We do peak flow meter every day before, during the session. They will blow 3 times and we measure the peak flow. We compare with data, see this is the best that we have achieved before. And we also evaluate ACT scores, CAT scores. We do inhaler therapy assessment for adherence and also the technique. So basically, in Respi MTech, we have taken 70% of the workload from the prescribers. So when you refer to me later, today we have Cherh clinic, I'm going to there later after this. So this is what we are doing on site, right in the clinic setting. So since Dr. John is also here, so I would like to emphasize that actually the presence of pharmacists and the space given for pharmacists to have in the clinic MOPD is very important as well. Anticoagulation, we're talking about warfarins. Hereby we are specifically talking about warfarin because when the patient was prescribed or started with warfarin, it is important for us to closely monitor their progress from time to time. So anticoagulation MTech was rather specific in pharmacies because it is really called a very authentic pharmacist-led services because it involves dose adjustment by pharmacists. Of course, this has to be done based on protocol and has to be credentialed and privileged before we can do so. So we do have one pharmacist who was given the privilege by Pengarah for us to do dosing adjustment based on protocol. So this is something very special. So the warfarin MTech was mainly run by the pharmacist. It's a warfarin clinic or among nurses kita panggil INR clinic. Setiap hari Isnin dan Rabu petang, INR clinic ataupun sebenarnya namanya MTech Anticoagulation akan beroperasi dekat MOPD. And one more important point is retrobiotitis. Patient-patient RBD yang dimulakan ataupun akan dimulakan dengan heart dan mungkin dah dimulakan dengan heart perlu dipantau dari semasa ke semasa. Kalau ikutkan setiap bulan kita ada satu sesi ID klinik dan sesi tersebut turut akan dihadiri oleh pegawai farmasi untuk memantau penggunaan ubat pesakit. Because we know our heart medications comes with a lot of adverse drug reactions perhaps, and there might be a lot of potential drug interactions that we need to address. So this is where the whole idea comes in. And also the non-compliance, the price to pay for non-compliance or non-adherence to heart treatment is very costly, very, very costly. So it is very important for pharmacists to help to ensure that every cent and every penny and cent spent was worth enough. Kalau tidak, jika patient fail the first line treatment, dia kena pergi ke second line, dia kena beli sendiri kan. Cost, adherence semua akan jadi isu. So kita kena pelihara tahap kepatuhan pesakit right at the first line of the treatment. So this is how it goes. For diabetes and respiratory, we can have patient selection criteria. Kita akan tengok jenis patient apa yang kita akan terima. But for anticoagulation and RED, there's no patient selection criteria. All patients started on warfarin and all patients on RED ought to be seen by pharmacists if they're starting on heart and so on. Meanwhile, at the same time, we also have non-MTech specialist clinic pharmacy services. Okay, some may wonder, apakah perbezaan antara dua ni? Bukankah farmasi juga hadir dekat klinik saja? It has a difference internally for our statistics and our declaration, because MTech services is supervised and monitored by our central bahagian perkhidmatan farmasi. We have to submit returns, statistics to the bahagian. But for non-MTech specialist pharmacy services, it was something less official because we are not bound to any specific returns and statistics. We just need to declare them under our respective pharmacy activities. So there are three divisions that we have, three disciplines that involve the attendance of pharmacists in this specialist clinic. One is nephrology, which me myself was involved. We just had one nephro clinic last week with Dr. Ching. So every time when Dr. Ching is attending the nephro clinic, I'll be inside as well. Dermatology, once in a month. So suppose we do have Dr. Loh Kun Cherh from HSB to come over, but this year is quite disrupted because of the COVID-19 pandemic, the PKPB and so on. So this year mostly we will be seen by our medical, our own medical specialists. But we do have pharmacists to help take care of the things, and also gastrohepatology. Semasa Dr. Razi datang untuk memulakan klinik hepatitis di sini, terdapat juga farmasis yang menjaga hepatitis, ubat hepatitis akan hadir bersama. So these are the 7 divisions that pharmacists had been involved in Hospital Sultanah Maleha. So this is for your knowledge. So I'm now would like to introduce our workflow. This is a very general, brief workflow that we have. Of course, I'll be projecting MTech specific workflows. So this is a general workflow that I've summarized. You can have a look at how do we do. So of course, on the first point, it involves referral. Referral can be done by anyone, can be done by either prescribers or pharmacists ourselves. Sometimes when the patient was admitted to the wards, I feel that this patient is not really good in terms of inhaler technique. While I've tried my very best to actually evaluate or correct the technique, I must ensure that this patient, when discharged, will be given good monitoring and able to maintain optimal inhaler therapy and adherence. So after discharge, to ensure patient did not readmit because of exacerbations, I will write a referral through the pharmacy CP4 form to my colleague to refer them to the MTech respiratory. So this is a contoh. If for doctors, kalau doctors yang prescribe or those who are online and offline, you may just fill up the counseling form and state up you want to refer this patient to Respi MTech. So we'll take the patient, we'll register in our registry, and we'll start seeing them. So we have to keep a registry of how many clients we have in our MTechs. We have to plug the patient's profile and history. We do have specific forms and documentations to monitor. It is not inferior than any of the services, any medical services in the ambulatory setting. We have to review a patient's understanding and adherence to medications. So there are a lot of chit-chat with the patients. Kita kena sembang dengan pesakit, korek rahsia mereka, tengok apa masalah yang berlaku. Kadang-kadang pesakit tu dia malu untuk berbuka mulut dia terhadap doktor untuk menyatakan masalah dia. Tapi bila sampai kat farmasi, dia akan cerita semua. So that's an advantage of having pharmacists because we can know the other side of the story. Review patient's clinical parameters. Sebab kalau nak tahu sejauh mana ubat tu berkesan terhadap pesakit, maka adalah penting untuk kita tahu clinical parameters dia correlate atau tidak. Contohnya HbA1c lah untuk di MTech. Kalau untuk asma, kita akan tengok ACT score, peak flow dan sebagainya. Kalau peak flow dia elok, optimal, that means it is good. Kalau COPD, kadang-kadang kita akan review FEV to FVC, spirometry dan so on. And also CAT score. Kita tak tahu berapa exacerbation yang dia pernah masuk hospital, berapa kali dia digunakan. Kalau anticoagulation, we'll talk about INR within the range specified by the doctors. and RVD, viral load, and CD4. Review on other drug-related problems. Jika pesakit tu komplain, kata ubat tu dia rasa tak selesa, kita kena tahu apa berlaku. Dan juga, jika patient tak menggunakan ubat dengan cara yang betul, ubat yang kena telan sepenuhnya, dia pergi kunyah. Boleh jadi juga kan? Because some of the medicines are entry-coated. Dia sengaja diformulasikan dengan tujuan agar tidak mengurangkan keberkesanannya. Tapi kalau cara makan salah, dia akan menyebabkan masalah berlaku. So we have to know all these drug-related issues through a checklist that we have when we encounter the patients. And also to provide customized education counseling. So when we have identified all the issues from the previous steps, this is when we start to tell the patient what to do next. And it is mostly a bi-directional interaction. It is not me towards patient only, blah 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 blah, habiskan tak. We have to find a middle pathway. Kita kena cari jalan tengah antara saya dengan pesakit. Contohnya kalau saya minta pesakit ambil ubat waktu sekian, waktu ni harus dipersetujui oleh pesakit tersebut juga. So kita kena berbincang dengan pesakit. This is when the session comes by. And we have to document all the progress notes and suggestions to prescribers. So for our prescribers, they will receive a note from us. So the best workflow is always, if the pharmacist involved, let the patient see the pharmacist first. Because in some clinics, but sadly, sad to say here, because our ratio of pharmacists to patient was less than that of doctors to patient. Clinic can have 10 doctors to cater the patients, but pharmacists only, we have limited numbers because we are less than doctors. Sometimes we can only pick and choose certain patients to see whom we feel that they are clinically indicated to our referral. But for most of the cases, we try to capture as much as possible in the sessions. Then when it comes to that, when they bring our progress notes to doctors will verify the points and they will try to have their decision. Then later on, they'll prescribe the medications to us. Dispense medication for me is towards more of a value-added services in the MTech. Because in MTech, our core business is always to ensure the patient's understanding and adherence. That means the counseling part is more important for me. So we can actually need to have an in-depth review on patients. All these are the core business for MTech. Dispensing is always a value-added service only. But it was included in the workflow per se. So here are all the these are from adapted, and actually we screenshot it from our protocols. So we have various protocols for various MTechs developed by our pharmaceutical services program. So we just need to follow, adapt and adopt. So kita ada protokol tempatan yang kita diadaptasikan daripada protokol-protokol diterbit oleh bahagian Jabatan Farmasi. So these are the very specific workflow. Tapi secara dasarnya, intipati dia adalah sama dengan apa yang saya nyatakan tadi. So ini MTech untuk RVD dan ini untuk anticoagulation. Ataupun di sini untuk anticoagulation harus saya tegaskan bahawa untuk masa sekarang kita hanya fokus more on warfarin dululah. Sebab anticoagulation turut merangkumi DOAX. We have dabigatran and so on, but we cover for warfarin first. So you can see, so one of the assessment important points is a dosing adjustment by pharmacists. So just now I've mentioned that we have patient selection criteria for DMPEG and RESP. So here are the general patient selection criteria we have. Mostly common between two is poor adherence to medications. And also if diabetes, patients are uncontrolled despite managed optimally. That means there's something wrong about the use of medication that has to tackle. Multiple comorbidities and medication. Kalau patient 5 ubat, insulin ada, ubat makan ada, then you akan expect patient tu mungkin ada masalah sikit. So you kena refer to DMTech, so kita tengok patient punya pencapaian tu macam mana. Patient have macrovascular and microvascular complications. Kenapa ni dimasukkan? When the patient has already developed complications, that means the treatment efficacy is not there. So you kena tahu apa yang kita kena cater. what are the pharmaceutical care plans that we can help to actually hinder the progression to worsen further. And of course, HbA1c more than 8%. This is something that we have to tackle. So HbA1c is one of the indicator which is being monitored numerically by our JKN as well. For respiratory, when a patient has asthma and COPD, ACT score equal or less than 19 is something that we take care about. This is for asthma patients because asthma jika kita kawal dengan elok dia boleh hidup seperti orang biasa. COPD lain. COPD once you kena, dia tak akan hilang terus terang, dia tidak akan hilang terus. Dia akan dibawa bersama-sama hari-hari. Cuma kalau kita guna ubat dengan elok, maka dia punya simptom dapat dikawal dengan bagus. But for asthma, if you use it well, if you control it well, you can live like a normal person. Uncontrolled asthma, memang kerap kali malam-malam bangkit, sesak nafas, lelah, batuk dan sebagainya. Those are called uncontrolled asthma. Daytime, nighttime memang tak henti-henti. Having frequent asthma observation. Kalau patient ni jumpa dekat hospital, orang ED boleh kenal, sebut nama sebab dia selalu datang NAP. Itu something yang kita kena tahu juga. So if let's say we have ED physicians that find that patients always can have a look on this patient later. And poor intent technique, of course. So how do we refer our patients? Senang saja, seperti saya cakap tadi. Kalau untuk doctors, we use medication counseling request form. I've discussed it with my colleagues, so we feel that the use of the form, you just note down there's an MTech there, then we can do the rest for you. If for pharmacists, we can use CP4 forms to refer. So this is our MTech profile to introduce. Okay, so diabetes, mellitus, and respiratory, the clinic sessions are held on Mondays. This is when we are stationed in the clinic itself, Mondays. Sometimes my colleague will be stationed in her pharmacy because Puan Sazwani is also the head of clinical pharmacy clinic Pakar, the OPD pharmacy. So sometimes due to job constraints, she need to stay in OPD. So she will see the patients in pharmacy. You can always live with her, ask her, hari ni cik tu kat mana? Ataupun you just get to preempt her for any patients that will refer, then she will do the rest. Extension 3331. So respiratory is the second Thursday of the month, which is today for November, which I'm going later. So Miss Ma is the first person in charge, extension 3334, followed by me. So either both of us can help. Anticoagulation, Mondays and Tuesdays, every week, 2 to 5 p.m., there will be 3 pharmacists there. Miss Noor Asnis Rosla is the pharmacist which was given privileging by pengarah to do the dosing adjustment. So dia kiranya orang wajib dalam MTech tersebut lah sebab dia seorang-seorangnya yang dapat latihan, dapat sijil dan dapat privileging untuk melakukan dosing adjustment. Nuriani Mustafa dan Jiha merupakan pembantu lah. Orang yang membantu juga pada masa yang sama. Jiha juga ada kat sini. Okay, and retroviral disease, which is the first Tuesday of the month in the morning session, which is in line with the ID clinic. So Miss Yue Li is the person in charge. So for non-MTech specialist clinic pharmacy services, so these are our scopes of services when we are sitting in the clinic. So we are dedicated on-site clinical pharmacy services. So we are there to be standby to receive any inquiries from the doctors or specialists. They will ask, ubat ni kota berapa? Teoh boleh tengok tak? Ubat ni macam mana dia punya pricing sekarang? So you have to be standby with all the information in your pocket and ready to answer the visiting specialist inquiries. So we have drug information inquiry, and of course, we'll be referred directly in the room itself to do counseling. So in Nephro Clinic, I have to do counseling also on how to use calcium carbonate, phosphate diet, and so on. So we do a lot of things inside. So these are the service profiles. So I'm the one in charge for the nephrology pharmacy service. Our frequency is 3 monthly, and mainly on Wednesday and Thursday. So I'll come together with Dr. Ching. But when we have free time, sometimes we'll pay a visit to the HDU and have a look at our patients because they are constantly there to do HD. So we have more time to actually do, we call it bedside review with them also sometimes. Dermatology by Ms. Noor Najiha Bohan, who is also present here. Monthly, on Tuesdays. So they follow the skin clinic schedule. Well, gastrohepatology is again is Miss Iweli, 3 monthly on Wednesdays. I don't know whether it's 3 monthly or 3 monthly. Suppose might be monthly based on the gastrohepato clinic lah. Okay. Any questions? I'm almost done. Yes. You use counselling form saja. Counselling form nanti kami hantar kepada doktor. Thank you. Yes.
Thank you for the lecture. I think it's quite enlightening to tell us your service is quite varied and quite extensive. But my question would be, and my interest would be, will you be ready for the introduction of the OPAT system in the future? How long, if you're ready, how long will you take for that?
OPAT, you mean?
Yeah.
We don't have any exposure with OPAT yet. If let's say we want to provide the service of OPAT, we have to get trained at least in hospitals Surabaya, or have to get further info from Dr. Sham first. Because if I'm not mistaken, only Sungai Buloh is currently having OPAT. If I'm not mistaken, they are one of the pilot centers is always Sungai Buloh who start all this OPAT system. But I learned about OPAT since I graduated actually. I learned about that, but I know that in Malaysia it was not mature enough. But let me talk to Dr. Sham further later on.
Because it's just curiosity.
Yes.
The thing is that if you have a good candidate for this OPAT program, then your bed occupancy rate also will be lower.
Yes.
You can avoid the problems of hospital-acquired infection in the sense that the patient can come in with infected ambulatory,
that's why
prosthetic joint infection, osteomyelitis. For example, if I were to take osteomyelitis involving sudomale,
yes.
because the rest of the already.
I agree much with you.
Yeah. Intensive phase, maintenance
yes.
phase, it will be great if we can incorporate it in the future. So, yeah.
But it really takes a lot of effort also and manpower. Because as I said again, warrant pejawatan untuk medical doctors, they are very easily imported from external facilities. You can add on a lot of contract doctors from time to time, but that doesn't work for pharmacy services, pharmacy program. So actually for us to start OPAT, although it's clinically proven as well, for those who are curious of what OPAT is, actually outpatient parenteral antibiotic therapy. Because if you know, patient kalau guna IV antibiotics, dia kena masuk hospital warded, served by the nurses. Tapi kalau katakan patient ataupun patient ada 6 weeks of IE cases contohnya, sometimes they have to stay throughout the 6 weeks of duration to ensure the antibiotic was served. But if it was OPAT, outpatient parenteral antibiotic therapy, dia macam TB tau. Patient akan hadir tiap-tiap hari ke pusat rawatan dan dicucuk dan dia balik macam tu. It's like DOTS punya therapy, but it's administered by the nurses. This is something that beyond my control and beyond my jurisdiction for the moment. We still need a lot of discussion in head. Yeah, I think this was very far. I also have to consult through Puan Nurul as well. Puan Nurul is here also. Yeah. It is really beyond our control for the moment.
I have a second question.
I
haven't joined IB training.
Yes.
So your job description also is covering the vitamin training for the IB patients.
Yes, I will show you the photo. Yes, this one. Pre-heart, initiating heart, follow heart. If the patient was diagnosed in the wards, they will refer for pre-heart counseling. So we'll go up to do the pre training. Pre-heart means we do pre-training. We have to educate them to get them accustomed with the lifestyle later, because this is a lifelong commitment from now until their graveyard. So that means this is something that they kena biasakan diri. That's why mula-mula kalau pre-heart counseling untuk maloban nurses dan anggota yang lain, kita akan bagi dia vitamin. So dia vitamin ni dia akan dimakan menyerupai ubat HIV dia akan makan lepas tu. So dia akan makan vitamin tersebut seolah-olah dia macam dia makan ubat HIV, sebab dia nak biasakan diri dengan gaya hidup tersebut, dengan waktu tersebut. Sebab HIV is something very specific. Dia tak boleh, it cannot afford a delay in your administration timing. Sebab virus ni dia sangat kuat dan kental sejak azali lagi. So dia akan tahu kalau masalah dia berlaku, kalau dia mampu merintang. Dia macam bakteria kita, dia mampu merintang sebab dia ada DNA dan RNA dalam tu. Dia ada sifat-sifat yang Tuhan jadikan dia sangat spesifik yang dia boleh melawan ubat tersebut dengan senang. So we cannot afford to have a delay, because daily taking of RBD medicine is meant to suppress the virus. Maksudnya dia tahan, kurungkan virus tu, jangan bagi dia melepak dalam darah dan buat hal. That's why. So kalau katakan dia dapat menggunakan ubat setiap hari, komitmennya cukup baik macam solat 5 waktu dan sebagainya, dia akan dapat suppress that viral load. CD4 dia pun akan meningkat. Viral load dia akan mengurang. Itu maksud dia. So if let's say currently, just to enlighten you, currently with heart treatment, the lifespan or the life expectancy for HIV patient can almost approaching normal patients as well, because of the heart treatment, which has given a lot of benefit to our patient. So again, the adherence is very important. If the patient tak sedia, if the patient is not really ready to take heart, it's very hard. But we hope that the patient can always be ready. So counseling tu sangat penting. HAART means highly active antiretroviral therapy, HAART. Kalau ikutkan sekarang, kerajaan Malaysia kita, KKM kita, banyak menggunakan dana untuk merawat HIV juga. So dan juga dikira berkesan selain daripada kita bagi apa-apa saja. Tapi sekarang ni, I think it is very important for us to take a look at all this lah. We don't want to wait our patients develop OI, opportunistic infection. Masa itu dah terlewat dah, patient akan meninggal bila masa saja. Okay. Any further questions? Nurses pun boleh tanya sebenarnya. Sebab korang kena tolong isi borang dan sebagainya. Kadang-kadang kena akan pelik jugalah. Kalau dalam ward tu apa yang berlaku, boleh tanya saja. If you're not clear with the impact profile, you can always contact me, because I'm actually the license officer for all these ambulatory care services involving pharmacists. So if you have any questions, feel free to contact me and I'll give you further info. No worries. I can be reachable through 3334 lah. So if no further question, thank you very much. Selamat menjamu selera for on-site participants. Thank you.